There's a new GLP-1 medication coming, and it's not just better than Ozempic. It's in a completely different category. It activates 3 metabolic pathways at once instead of 1. The weight loss numbers in clinical trials are unlike anything we've seen before. And I want to talk about why that excites me and why it also concerns me deeply. Because I called this a few years ago when everyone was celebrating semaglutide. I kept asking, why are we only targeting one incretin hormone? Why just GLP-1 when you could stack them? The biology was always pointing towards this. Well, here we are, and now I have more questions than ever. Let me lay out the science first because it matters. The drug is called Retatrutide, and I want to credit Dr. Ben Bikman here, metabolic scientist and professor of cell biology. He's a hero of mine. His book, Why We Get Sick, changed my life, because his breakdown of this molecule is the clearest I've seen, and it's worth understanding. Every GLP-1 drug you've heard of, Ozempic, Wegovy, activates one receptor, one pathway. Tirzepatide, that's Mounjaro and Zepbound, added a second, GIP, 2 pathways. Retatrutide adds a third, glucagon, and that third pathway is what makes this a completely different kind of drug. Here's why. GLP-1 and GIP work on the input side of energy balance. They reduce appetite, they suppress cravings, they make you eat less. Glucagon works on the output side. It increases fat burning, it raises energy expenditure, it drives the liver to clear its fat faster than anything documented before. In clinical trials, the weight loss numbers are around 24 to 29% of body weight. To put that in context, semaglutide produces roughly 15%. Tirzepatide around 20. Retatrutide is in a completely different class. And the liver fat data? In one phase 2 trial, over 80% of participants achieved normal liver fat levels, nearly 90%. That's remarkable by any measure. So yes, it works. Probably better than anything that came before it. Here's where I want to be direct about something. The evolution of these drugs was always predictable if you understood the biology. 1 receptor agonist, then 2, now 3. The next step after Retatrutide will probably target 4 pathways, and then 5, because that's how pharmaceutical development works. You find what works and you push it further. And every time the numbers get better, every time the clinical trial results are more impressive, every time the medical community celebrates another breakthrough. But here's the question I keep coming back to. Better at what exactly? Better at producing weight loss while the medication is active? Absolutely. The data is clear. But what are we building underneath? What is the metabolic foundation that person is standing on when the drug stops? Because this is the pattern I've been watching, and it's the pattern that built this entire platform. The medication works, and then it stops. And then what? With Retatrutide, we now have a molecule that is more powerful at suppressing the metabolic dysfunction than anything before it, which means when it stops, that gap between what the drug was doing and what the body can do independently may be wider than ever. And here's where I need to say something that nobody in this conversation is saying loud enough. If you are on one of these medications, any of them, and you are not simultaneously repairing the foundational issues underneath, the micronutrient status, the protein to energy ratio, the muscle preservation, the hormonal environment, you are not building anything. You are borrowing. Dr. Bikman himself makes this point, and I respect him enormously for it. He describes these drugs as a crutch, his words, a crutch that helps someone who can't yet walk on their own. And he's explicit. The goal should be to need the crutch less and less over time. The best outcome is to put it down entirely. And I agree with that completely. But here's the reality of what I see in the people who come to me. Nobody gave them that framework when they started. Nobody said, this is temporary. Here's what you need to build while it's working. Nobody explained that the caloric deficit that the medication was creating was also reducing lean tissue and muscle mass. Nobody explained that muscle is the metabolic engine, that less muscle means a slower resting metabolism, that a slower resting metabolism is the beginning of a trajectory towards frailty, sarcopenia, osteoporosis, metabolic fragility. These are not dramatic sudden events. They are slow compounding processes that begin quietly, often during a period when someone feels like they're finally winning. And now we have a drug that is more powerful, that produces more weight loss, that suppresses more of the body's own signals more completely. If the crutch is bigger, the dependency risk is bigger. That's not a controversial statement. That's physics. I want to be careful here because I'm not anti-science. I'm not anti-medication. I work with people navigating life after GLP-1s every day, and I understand this biology. But I am someone who has watched enough health cycles to know this pattern. Every time we find a powerful pharmacological lever, every time we engineer something that overrides a complex biological system more completely, we celebrate the numbers, the weight loss percentages, the liver fat clearance, the blood pressure reductions, and those numbers are real. The benefits are real, but biology is not a machine, it's a system, and systems respond to override. GLP-1 medications were the most powerful metabolic intervention most of these people had ever experienced. And when they stopped, the system responded. Ghrelin rebounded, leptin signaling disrupted, muscle mass reduced, metabolism slower. The rebound was proportional to how completely the drug had been overriding the system. Retatrutide overrides more systems, more completely, with a glucagon arm that is driving fat oxidation and energy expenditure at a level the body has never produced on its own. What does the rebound look like when that stops? I'm not asking rhetorically. I'm asking because nobody has that data yet. Because the drug isn't released yet, maybe by the time this video. Because we are, as we always are with these things, celebrating the breakthrough before we understand the full picture. And the people who will live with that full picture are the people this platform exists for. Here's what this all comes back to for me. There is no off-ramp. There wasn't one for semaglutide, there wasn't one for Tirzepatide, and unless something changes fundamentally about how we approach these medications, there will not be one for Retatrutide either. The medical system was built to prescribe these drugs, not to help people stop them successfully, not to address the biological environment after discontinuation, not to repair what was broken before the drug started and what remains broken when it stops. That's not an accident, that's a design. And when the drug gets more powerful, the need for an off-ramp becomes more urgent, not less. And this is what we're building here at Life After GLP-1s. Not an argument against the medication, an argument for the conversation that needs to happen alongside it and after it. What are you building while the drug is working? What is your metabolic foundation? What's your muscle mass doing? What are your micronutrients doing? What is your protein to energy ratio doing? Because if none of those questions are being asked, and for most people they aren't, then the drug isn't a bridge to metabolic health. It's a bridge to the next drug, and the next one after that, each one more powerful, each one overriding more completely, each one making the system more dependent on the override. That's not a health outcome. That's a pharmaceutical trajectory. Retatrutide is impressive. The science is real. And Dr. Bickman's breakdown of the glucagon receptor mechanism is genuinely fascinating. The futile cycling, the liver fat clearance, the energy expenditure data, I find all of that compelling. And I still believe the context matters more than the molecule. A more powerful drug in a broken system without a repair protocol is still a more powerful drug in a broken system. I was overweight my whole life. I reversed it without any of this. Not because I have extraordinary biology, because I eventually understood my own biology well enough to give it what it actually needed. That option exists for more people than the current conversation suggests, and it will continue to exist, regardless of how powerful the next drug is. The off-ramp is real. We're building it, and we're doing it here, because this conversation needs to be accessible to everyone who needs it. If you want to understand what your metabolic foundation actually looks like right now, leave a comment below and I'll reach out personally. Subscribe for this explained every week. And if this made you think, share it, because the people who need this conversation are out there looking for it, and we're creating it right here.